everyone for joining us today. We're very excited to meet Dr. Nolen and hear from our new epidemiologist. I just wanted to set a couple quick ground rules. First, I want to ensure that this is a safe place. Any opinion, any position, any question, everything's on the table. This is a judgment-free zone. We're just here to share information and to learn from Dr. Nolen. And second, as you ask questions, Dr. Nolen likes to keep this kind of dynamic. So there's a couple different ways we can do this. If you are comfortable unmuting and asking your question, I will ask you to all stay muted until you're asking a question. Raise your hand, we'll acknowledge you so we don't all speak over each other. You can ask your question live, or if you're more comfortable with that, you can ask it in the chat and we will relay the question. Just keep in mind, we have an hour. We're going to try to get through as many as we can. So keep your question to a question as concise as possible and mix, just keeping in mind that there are other people behind you that will have questions as well. So with that, I'm going to give you a short introduction on Dr. Nolen, since I think most of us are meeting her here for the first time. Dr. Leisha Nolen is MD, PhD, joined the Utah Department of Health as the Utah State Epidemiologist earlier this year. She received her undergraduate degree at Cornell University and her MD and PhD at the University of Pennsylvania. She trained as a pediatric resident at Boston Children's Hospital and postdoctoral fellow in basic science genetics at the Medical Research Council in Edinburgh, Scotland. In 2013, Dr. Nolen joined the CDC as an epidemic, I'm just saying epidemiologist, epidemic intelligence service officer in the bacterial special pathogens branch. And I'm imagining that involves a lot of like hazmat suits and very Hollywood-like. During this time, she worked on a number of investigations related to a variety of deadly infections, including working in the 2014 Ebola response in West Africa. After finishing the EIS program, Dr. Nolen was hired by the CDC's Field Epidemiology Training Program. That sent her to Vietnam, where she led a training program for local public health workers. In 2016, Dr. Nolen joined CDC's Arctic Investigations Program, an Anchorage-based program that focuses on the health disparities in the Native Alaskan population. Over the past year and a half, she's been involved in many activities related to the SARS-CoV pandemic, including helping establish a national system to track COVID-19 vaccine breakthroughs, evaluating the accuracy of the rapid tests, and working with Alaska Native villages to establish an approach to protect their communities. And she started with the Utah team in July, immediately joining Utah's COVID response team. And we're very excited to have you. So with that, I will turn it over to Dr. Nolen.
Thank you. And yeah, it didn't involve too many hazmat suits. Sorry, I know it sounds exciting when you say CDC and outbreak investigations, but often it's not that exciting. Luckily, actually. So I'm going to share my screen here. So first, we thought it would be useful to just go through some basic info about where we are right now with COVID in Utah and some data behind vaccine safety, because I think that's what a lot of physicians I've heard are being asked. So I wanted to give you information to help you be able to answer those questions. So first off, where are we in Utah with COVID? As I'm sure many of you know, we are in a high plateau. We've had this sort of Delta wave sort of just extend onward and onward here in Utah. Unlike other places where it came and went, we have it continuing on. And what this really means is, in terms of concern, is that it's making our hospitals really over capacity. So usually we consider 85% of a hospital being full to be where we, like the max we ever want to be at, because that's where we give good patient care and can respond quickly to changes. As you can see, unfortunately, we've been past that since September. So we've been beyond what we consider ideal capacity since September, and we've been really around 100% full at our hospitals here in Utah. So really concerning. Our total hospitalization as of yesterday was 26,000 people have been hospitalized for COVID here in Utah. So the number is not small. Deaths also concerning. As you can see, we have this peak back in winter last year, what we all thought of as the Christmas peak last year. We have almost as high a peak right now, and we continue to see lots of deaths occurring, unfortunately. And we have over 3,000 deaths right now recorded due to COVID. So really, we're having big impacts in our community. So what is the solution? So the solution really is vaccines. This is graphs of both cases and deaths. The orange is unvaccinated people and the blue is vaccinated people. And what you can see, well, orange, for the first year, we only had unvaccinated people, so there was no blue line until beginning of January, you can see there's a huge difference between the rate, and so this is rate, so it's corrected for how many people are eligible to be in these populations. You can see there's a huge difference in the rate of cases, and an even more extreme difference in the rate of deaths between those people who are vaccinated and unvaccinated. So we really can see an impact of vaccine in our population, and this is Utah. And then if we look at just numbers for the overall time period, if you're unvaccinated, you're 2.5 times more likely to test positive for COVID. You're almost 6 times more likely to get hospitalized for COVID, and more than 6 times more likely to get die of COVID. And if we just look at the past month, we actually see even better protection of the vaccine, and that we think is likely related to many people getting the booster. So unvaccinated people are 3.5 times more likely to get COVID, 9 times more likely to go to the hospital, and 12.7 times more likely to die. So in this past month, we are really seeing a difference between the severe disease of COVID in the unvaccinated people and the vaccinated people. So it works. And then also even just at a community level, we can see the more people vaccinated in the community, so the further you go up this graph, the less cases you have, so the further you go over here. So highly vaccinated communities have less cases, low vaccinated communities have higher cases. So we're seeing vaccine not just at the individual level, but at the overall community level. And then there is a lot of discussion about long COVID. I'm sure many of you are seeing patients with these some of them very vague, very difficult to determine what is the cause, symptoms after COVID. And so one thing to consider is it's not that COVID, the vaccine just protects you against infection, and not just that it protects you from going to the hospital, not just that it can protect you from dying, it protects you and your patients who get vaccinated from long COVID. There's definitely data saying that there is the possibility for people who have breakthrough infections to have long COVID, but the risk is much lower than people who are unvaccinated. And the symptoms are much less severe and less significant. So when you're talking to patients, I think you can lay out all these benefits. It's not just that you're going to stop them from going to the hospital and dying of COVID. They're not going to have these long-term consequences of COVID. So we're slowly getting more and more information about that, but it is showing that vaccine protects against that when you do have a breakthrough infection. And the reason I'm talking to all of you and asking you to take your lunch break to listen to me is that we realize you are really the key to getting people vaccinated and protected against COVID. So study after study shows that the top person that people will listen to about COVID is their hospitals and doctors. So we really are reaching out to you, any kind of clinic staff, to really talk to people about the vaccine and try to get people to feel comfortable getting vaccinated. So some facts about vaccine, the COVID vaccine, medical conditions that should not stop patients from getting vaccinated. I hear from numbers of people like, oh, I have a food allergy, I shouldn't get the vaccine. Oh, I'm allergic to eggs, I shouldn't get the vaccine. There's a number of things that do not disqualify people from vaccines. So immune conditions, we really actually want to encourage people with immune conditions to go get these vaccines. There's no indication that these vaccines trigger any kind of exacerbation of immune conditions. So we really want to push for those, not a contraindication. Pregnancy, definitely not a contraindication. In fact, more and more studies are showing that people who get COVID while they're pregnant are much more likely to have severe disease and much more likely to have negative pregnancy outcomes. Whereas there's now a lot of information about people who did get vaccinated while they're pregnant, and there's been no indication that there's a higher risk of birth defects or preterm labor or gestational failure. So pregnancy, we really want to get those people vaccinated. It's not a contraindication. And then Guillain-Barré, Bell's palsy, sort of they fall into those autoimmune conditions, not a contraindication. And all those common allergies, allergic reactions out there, those are fine. Even latex, people have concerns about the stoppers of the vials. The stoppers are not latex, so no need for concern about that. And then the delayed reactions to the first vaccine. I think you've seen a lot of people come in where they have the swelling of their arm. They have sort of, the induration almost looked like we got a TB test. That does happen, but it's not a contraindication. That is a reaction to the vaccine, which is appropriate and does not suggest any severe reaction to the next dose. So all these things are not reasons to contraindicate, are not reasons for people to get the vaccine. So what are the reasons someone should be considered not to get the vaccine? Well, specifically, if they've had a severe allergic reaction to the first dose. So someone who had anaphylaxis to the first dose should not go on and get another dose. And that really crosses between the two different mRNAs. So they got Moderna, they should get Pfizer, either or. But they could be considered to go and get the Johnson & Johnson because they are such a different vaccine. They also, people who had the immediate allergic reaction to of any severity to the vaccine. So it's not something that comes out a day or two later, it's an immediate allergic reaction. And then people who have diagnosed allergies to the components of the vaccine, which we'll show in a moment. So here is a full list of what's in these vaccines. I just have included in this slide set because I will send you all these slides just so you have it, but I'm going to pull out the information in more so you don't have to read that whole table. So specifically the mRNA vaccines have a PEG component. So therefore people who have a known PEG allergy are generally contraindicated against the mRNA vaccines. And so they could then consider to get a Johnson & Johnson vaccine because there is no PEG in the Johnson & Johnson. The recommended dosing would be almost as if you did PEG, the mRNA or Moderna, you realize they have a PEG allergies, then you can give them the Johnson & Johnson 28 days later, almost as if you were doing a regular spacing for Moderna. And then sort of the opposite way, Johnson & Johnson vaccine has a polysorbate component. So those people who have those kind of allergies would be considered contraindicated for the Johnson & Johnson. And we'd really encourage them to get the mRNA vaccines because there is no polysorbate in the mRNA vaccine. And therefore, it's really safe for those people. So those are the two allergies that are specific, but it's nice. They are different in the different vaccines. So you could choose to use one or the other based on the person's allergies. Again, just a list of the contraindications and how to work with them that's listed on the CDC site, and I'll send this out so that you can all look at it in detail if ever useful in the future. And then side effects, because I know there's a lot of people concerned about the side effects of these vaccines. So one thing to say is all this data comes through CDC, through the VAREs and VSafe system. I hope all of you have taken part of reporting any side effects you see to VAREs, because it really is how we understand what is safe and what is not about this vaccine and really any vaccine. So all this data is looking at data through December 6th, which includes 470 million doses of the vaccine. So very large sample size. And of those 470 million doses, it means 235 people have gotten at least one dose. So we have a huge number of people being tested, given these vaccines, so we can have pretty reasonable information. And we have, CDC has a number of systems up to really do real-time analysis of these to make sure there's no concerning trends that come up even in the short term. So anaphylaxis, we all heard about anaphylaxis from the very beginning. Everybody was worried about this. It turns out it's exceptionally rare. It looks like about 2 to 5 people per million who were vaccinated have this anaphylaxis reaction. So it didn't turn out to be that big of a concern at all. Myocarditis and pericarditis. This has been in the news, and I'm sure many of you have heard about it. So as of November 24th, there were 1,949 reports of myocarditis into VAERS. CDC and FDA have confirmed a subset of those, about 1,000. And they have seen that there is definitely a predominance in male adolescents and young adults. The risk for females is really no different than what a background risk would be. And it's specifically seen a few days after the second dose of an mRNA vaccine, so either Moderna or Pfizer. And the good news is that these cases of myocarditis and pericarditis are very mild and respond well to treatment. And so for one case, they've done studies in military members, which actually is a very good population for this since we have young adult males. And they found that they had 10 cases per 1 million doses. When they specifically looked at males under 20 years of age, they got up to 100 cases per million doses. So that is definitely the highest risk group, those young males. And of those 100 cases per million, they were able to show that 2/3 of them reported feeling fully recovered within 6 weeks of their diagnosis. So obviously there are some that still have some symptoms after 6 weeks, but the majority do go on to recover completely. And when a similar study was done in the VA, which is an older age group, they found no association, which again suggests that this is very specific to young males. And a Danish study also looked at this, and they specifically looked at 12 to 17. Oops. 12 to 17-year-olds, and they found that there was a slight increase of myocarditis after these vaccines, but they found it was very much slower than the risk of myocarditis compared to when people got COVID infection. So small increase of myocarditis related to these vaccines in a specific age group and population. Guillain-Barré, so VARES has received 268 reports as of November 24th. These were specifically seen in men 50 and older and who had gotten Johnson & Johnson. So you have to consider we have 268 reports and 16 million doses of the Johnson & Johnson vaccine have been given. And then Israel has specifically looked at people who had previous episodes of Guillain-Barré, so theoretically the people most at risk of having another trigger with a vaccine. They studied 702 people who got this, and they only found 5 people who went in with any symptoms, and most of them were thought to be related to, not directly related to the vaccine or Guillain-Barré, and all of them were discharged within hours. So even in this very high risk group, the incidence of Guillain-Barré is very, very low, if at all, related to the vaccine. The next one is thrombosis and thrombocytopenia syndrome. So this is the one where clots are occurring and was the hold on Johnson & Johnson earlier this year. There have been 54 reports of those as of November 24th. This is specifically with the Johnson & Johnson vaccine and women of reproductive age. So far there have been 6 deaths reported with this syndrome. But we need to keep in mind that there are 16.4 million doses given out, which would be 16.4 million people in Johnson & Johnson case. And so 6 deaths, 54 cases out of 16.4 million cases. Of those deaths, and then in addition, there have been 2 confirmed cases following an mRNA vaccine, Moderna specifically. And when they did analysis, they found that was not at all above what would be expected when you gave 437 million people a vaccine. 2 cases would just occur in the population despite vaccination. So the only linkage seen here is to the Johnson & Johnson vaccine with women of reproductive age. And then death, certainly we've all heard a lot of reports about how people think there's a huge amount of death occurring because of these vaccines, which is of course completely inaccurate. So as you know, FDA requires healthcare providers to report any death related to the in time relation to the VARES vaccine, the COVID vaccine to VARES. And that's true no matter what the cause and etiology of the vaccine related to the deaths. So that means many of the reported deaths are not related to the vaccine. And it's really then the onus of CDC and FDA to evaluate whether or not those deaths are related at all to the vaccine. So of the 459 million doses of COVID vaccine that's been given out, there's been 10,128 reported deaths, which comes out to 0.0021% of all the people who have received the vaccine have died. And that is just all-cause death, not death related to the vaccine. So there have been 6 deaths of the thrombocytopenia syndrome that are thought to be likely related to vaccine. And those are really the only deaths that have been firmly associated with the vaccine. So 6 definite deaths and then 10,000 deaths that are very likely most not related to the vaccine. But even if you were to consider all 10,000, it would be a very, very small portion of people. So how does this look? My graphic didn't come out right, but here we go. So if we put all these numbers onto scale, so if we do cases per million people who got the vaccine, well, we have anaphylaxis at 5, we have myocarditis specifically in the mRNA group at 2.3, Guillain-Barré, which is specific to the Johnson & Johnson at 16.8, thrombocytopenia syndrome, which is specific to Johnson & Johnson at 3.4, and death, which is a huge overestimate at 50.9 cases per million people who got the vaccine. And so those are all really great numbers, and then they all become super little when we put them next to COVID deaths. So I think it is really important to keep this last graphic in mind. Even if every single one of these cases is truly COVID related, COVID vaccine related, it significantly is drowned out by the risk of COVID itself. So exceptionally safe vaccines, and exceptionally well performing vaccines. So the summary that I have is that really everyone should be able to get a vaccine. You can pick the type that fits the person. So personally, I think a reproductive age female, I would avoid Johnson & Johnson, and Moderna and Pfizer are much better choices. You can look at those specific allergies, whether or not it's PEG or polysorbic, and choose the one that fits better. And if the person is at risk of Guillain-Barré, there's a slight preference to go for one of the Moderna vaccines. So the last thing, I realize there's two more. Previous protection from previous infection. There's been a lot of talk about this, especially in Utah, about how good previous infection is protecting people. And there is no question, a previous infection does help people fight off a future infection. There's no question. Our immune systems learn, and thank goodness they do. But it is shown that the previous infection is not as good as having an additional layer of protection with the vaccine. So there's data emerging that really shows even if people have had previous infection, they really will benefit from a vaccine. So Israel was able to show that previous infection had a 94% efficacy against hospitalization, and Qatar was able to show that people with previous infection were 8 times less likely to have a serious infection than those without a previous infection. So that shows previous infections do help, but the addition of the vaccine is clear. There's hospitalization data from here in the US where it was shown that people who had the vaccine were 5.5 times less likely to be hospitalized than those people who had a previous infection but were not vaccinated. And in the Israel population, they were able to say that people with previous infection and vaccine, the two together, were 2.3 times less likely than the unvaccinated people to have future infection. So with that, I'm going to stop, and I'm happy to take questions from whoever has any issues.
Thank you so much, Dr. Nolen. I wanted to read this comment that I would love to have your thoughts on from Dr. Ferguson. I would be worried about reporting those death stats to the public. Many laymen may see that as unclear or even correlated when it is not. Can you talk a little bit about, because I know that not everybody on this call is a physician. There's a lot of public health folks on here as well. Can you talk about the VARES system a little bit and how some of those numbers are being misused?
Yeah, I think you're totally right. It is difficult for general population to look at these numbers and be able to evaluate them critically. So the VARES system, as we know, it requires reporting of significant events after a vaccine, and that is over. It doesn't have a time span even. So anybody who dies theoretically after their vaccine has to be reported, and that could be for any number of reasons. And so what CDC does is it takes all those reports, whether it's death or whether it's heart attacks or whether it's strokes, and they look at what time frame the event occurred relative to the vaccine. So first, was it closely related or was it months after? And then they need to look at a population that didn't get the vaccine, because we know if we didn't do anything at all, there's going to be many people who, when you have 300 million people get something, you're going to have many people die and have strokes and have heart attacks, just because it happens, right? So we have to then compare how many would occur no matter what we do. Like even if we just gave them a sip of Kool-Aid that day instead of their vaccine, and how many occurred when we gave them the vaccine, and compare the two to see how likely it is the vaccine actually increased those events versus it was just the background that we're seeing because everybody's looking for it. So that's what CDC and FDA do, and that's where they go and they evaluate all these trends. The only one they've seen any increase in the death signal is with that clotting disorder, specifically to the Johnson & Johnson. All the other deaths so far are not triggering that it's higher than what we expect. 300 million people, we're going to get many deaths. And so that's what they need. And it is an analysis, and they keep a very close eye on it. But you're right, it is something that we need to be cautious about how we message, because I think that is what is misused by people who try to discourage vaccine.
So maybe it's just only report the thrombus, the associated, the 6 deaths from the J&J, and say this is the only closely linked that was secondary to receiving a vaccine out of hundreds of millions of doses. I mean, we could even probably take it to billions. Yeah. You don't report VAERS data when having a discussion with a patient that is still on the fence or resistant. Maybe that's the, hold off on theirs, only what's truly like in a study or case reports.
Yeah, I think you're totally right. So the 6 cases is the VARES data. I think you're completely right. I think I'm giving you this information because I think as providers, physicians, it's important for you to understand the data behind it so you can feel confident when you talk to your patients. But certainly I'm not going to sit down as a physician. I'm a pediatrician. I wouldn't want to sit down with a family and go through this because it raises so many questions. But I think you're right, talking about like, we know Johnson & Johnson has a handful literally of deaths that are thought to be due to this clotting disorder. And we know it's specifically for Johnson & Johnson and women of reproductive age. Therefore, for you, I'm going to think we don't go there. So that's that. I think you're totally right. You need to have it more as a conversation with the person that's at what they understand and level that makes sense.
Thank you. I'm going to read a question from Dr. Lindsay Drew. I have had patients who only compare case counts from late 2020 to late 2021 and don't feel like the vaccine has impacted the daily case counts in Utah significantly. What details do you find helpful to share with patients in this situation?
Yeah, so the big difference, right, is Delta. So one has to only imagine how horrible this fall would have been if we weren't vaccinated and Delta came through. So I do think the things to talk about is the cases we are seeing is in the unvaccinated. And actually, I should be more correct in saying the hospitalizations and deaths we are seeing are the unvaccinated. We definitely see breakthrough infections. There's no such thing as a perfect vaccine. So of course, we're going to have some breakthrough infections. And so we definitely see a fair number of cases in our breakthrough infections. But if we look at our hospitalizations, those are almost all people who are unvaccinated. And our deaths, it's even more extremely skewed. So talking about, well, thank goodness we have this vaccine, or else it would be really tragic this year because then everybody would have been susceptible. Right now, it's really the unvaccinated people who are susceptible to those severe cases. And so it is something that we have the cases, but we are preventing people from going to the hospital with that vaccine, which is really what we need.
How much do you think, on that same note, I think we can probably all say that life out in public looks very different this December than last December. We don't see the masking. I realize that there were some counties that didn't have a lot of masking this time last year, but even in Salt Lake County, which was pretty highly masked last year, we're out in public, it sort of looks like December 2019. Do you think the lack of mitigation efforts is also in play?
Yeah, you're completely right. Yes, we've changed our behavior. Last year, we kept the case count down because of how we behaved. We had a lot of things closed for a certain period of time. Our kids weren't in school. So you're completely right. It is a combination of that and then Delta coming through.
Any other questions from folks? You're welcome to type into the chat. You're welcome to go ahead and speak up if you want to ask any questions about these vaccines. I knew this was going to come up. Let's go ahead.
I did too.
Let me go ahead and ask Dr. Ferguson's question, and then we can start talking about Omicron. Is it too early to have the discussion of how COVID has become endemic, no longer a clear pandemic, to our population and how mutations relate to endemic? So that definitely relates to the discussion about the new variant, the scariest sounding Greek letter.
Yeah, so we definitely at the Department of Health have been talking about where we are going in terms of how to deal with this as an endemic disease versus an epidemic disease. I think there's all these definitions, but I think in my mind, the thing that makes the difference is when can our hospital systems deal with it and when are they completely overwhelmed? And unfortunately, we're still in that overwhelmed. Our hospital systems are above 90% full, and it's, at least in the adult hospitals, it is COVID. In the children hospitals, there's a combination of RSV, COVID, and a lot of other childhood illnesses. But the hospital systems are still overwhelmed. So we still kind of need to act like this is an epidemic. We are talking a lot about trying to switch over to more normalizing this, acting like a flu model as things go forward, because I think that's what we will need to do. Both because of burnout and because of reality is we need to get back to normal and treat cases is not as important. But so right now, I mean, we don't know what's going to happen to Omicron and what's going to happen with future variants. But right now, if I get COVID, I am so unlikely to go to the hospital because I'm vaccinated, I'm boosted. And therefore, is it really necessary to track me? It's much more important to track the severe cases. So I think as we go forward, we're going to be more and more focusing on trying to look at the severe cases than on all cases. And that's part of our slow transition towards the more endemic state. But it's also making sure we have capacity throughout all of our systems to be able to test people when they come into clinics and be able to protect people when they are exposed. And so getting towards that is definitely something we've been working towards. If only we had a break in between that we could set all that up.
I do want to
But
interject.
Omicron.
Well, let me interject this question real quick before we move on to that, because I do think this is important, and particularly in messaging. Steve Nelson asked, have you encountered people questioning our at capacity hospitalization numbers as actually resulting from decreased staffing and layoffs?
Yeah, I mean, that is partially true. There is definitely, the hospitals are having a really hard time keeping staffed, but unfortunately, that doesn't make a difference to whether or not we get good care when we go into the hospital. What's the reason? These hospitals are not able to take care of us because they don't have the staff and because there's so many COVID patients. If we were in the percentage I show you on the graph is percents the hospitals being full. I could have also shown you a graph where it shows number of people in the hospital, and it actually, our numbers look very similar to last year. So it isn't a pure lack of staffing. It is that we just have a very large number of people in the hospital still.
Yeah. Do you want to go ahead and start talking about what we know about Omicron? And
that's a really short discussion. We don't know much about it.
Don't know much. I know. Can you talk about your thoughts on yesterday about the data that Pfizer released regarding, at least in lab studies? Can you talk about a little bit about what, maybe even just, I think there's a couple good questions to address. One, what is it that they're looking at? And two, I have a question, I think that is a fair question, especially with your experience with the CDC. Why is it that the US doesn't do more close monitoring of these emerging variants like other countries do? So if you could kind of address both of those.
Yeah. So, okay, first, what does the Pfizer data suggest to me? So I think there's actually good news in that Pfizer data, and that the antibodies from people who have been vaccinated. So they took blood from people who have been vaccinated. They look for whether or not those antibodies can bind to the Omicron variant and essentially neutralize it. And they find it does bind. So that's great news. I think that's the worry, is that it was just going to not even recognize it at all, but it does bind. It binds with lower affinity. So the way to get around a low affinity antibody is just to put a lot of them in. So that's why I think a lot of the reports today and yesterday that are based off of Pfizer is this idea that we might need to boost earlier. And certainly it's a reason to try to encourage everybody to go get their boost. Because if you have a low level of moderate affinity antibodies, you're going to have, some virus is bound, some virus can sneak through. If you have a lot of low, medium affinity antibodies, then you are able to neutralize those much better. So I think the data, at least to me, is at least partially good news. I like that it still binds, and we can certainly get people boosted and make sure they have really high levels in their body. They are able to still neutralize those virus. The other thing to remember is that they are only looking at antibodies, and certainly I have to admit I've mostly blocked out my immunology course, but there's that whole other part of immunology with the T cells and all that stuff. And so there should be an immune memory that is related to that as well in all of us who got our vaccines. And so they weren't able to test that in the studies they did, and it will be interesting to see the combination of T cell and B cell response, how much we are protected. But at least one layer looks like it's reasonable.
Good. And then in terms of monitoring variants in the US, can you talk a little bit about that?
I mean, I think that is just, unfortunately, we haven't had huge investment into our public health system in the US historically, and that means we don't have the capacity starting now. Whole genome sequencing is a fairly large investment. I can proudly say Utah possibly has the highest sequencing capacity per capita of anywhere in the state. So we actually are doing very well. We are able to, we're sequencing about 10 to 15% of all of our positives here in Utah. We actually, and with that turns out to be about 20 to 25% of our PCR positives. As you can imagine, we can only sequence the PCR positives, the antigen positives, there's not a sample we can sequence. So 20, 25% of our PCR positives, which ends up to being about 10 to 15% of our overall positives. So in Utah, we actually have a very good system to pull in those samples, and we're trying to make sure that we get them from all different parts of the state so that we can get a fairly good idea of what's happening and not just one spot. But across the country, it's a large investment that unfortunately we hadn't focused on prior to this.
I got a question from Dr. Mark Wardle. As we are discussing Omicron and future variants, how important is it that we advocate for global vaccine equity as we are getting boosters in other communities around the world who are struggling to get their first shot?
So it's so challenging how we distribute. I really do agree with you. We need to get those vaccines into everybody's arms, not just the United States arms. And I think that's a policy that we need to all push for and try to get it out there. My understanding is us taking a booster is not actually the big limitation these days. There can be vaccine given to other places. It's then distributing in those places. Giving people vaccine is only so helpful, especially these vaccines that you need these ultra cold storages. We need to get ways to get them into people that live out in areas that do not have access to those kind of things. So us taking a vaccine is I don't think the biggest part of the problem right now. It's we need to get resources into different parts of the world to get those distributed and actually into people.
Some of the foreign vaccines, for instance, in many of the missionaries for the Church of Jesus Christ of Latter-day Saints are in foreign countries that have Sputnik or Sinovac. Do you have any data as to their effectiveness?
I don't. I know that I believe all of them are approved by WHO except for Sputnik, because I know WHO has given sort of essentially the equivalent of an emergency use authorization for all these different vaccines. There's many different vaccines now, right? But I don't believe Sputnik is still on the list, and so I haven't looked into the data behind it. I think that might be the issue. I don't think there's much data on Sputnik. The others are generally accepted by the WHO.
But can you talk a little bit about how there was some hesitation to recommend vaccines for pregnant women in the beginning, and now trying to get past that old messaging?
Yeah, and I can totally understand. I mean, it's nerve-wracking to give someone who's pregnant something that is fairly new, right? We that's such a high-risk individual, and two individuals really. So I can understand the hesitancy, but I think now the data has become really good. We have had, I mean, hundreds of millions of people have received these vaccines, and among them, many, I don't have the numbers in front of me, but many thousands have been pregnant. And so there is data coming in from all these women who are pregnant and vaccinated, and really the risks are non-existent. We have data, there is a CDC study where they looked at risk of miscarriage, and there was no increased risk of miscarriage. And initial birth defects, no initial birth defects to find. Of course, we do want to make sure the babies don't have anything over the long run. But thinking about the technology, especially the mRNA vaccines, it's something that gets injected in your arm and it does not travel far at all. And then it puts its RNA machinery essentially into your cells, and you crank out some protein. And that's what you respond to, right? Your immune system responds to those proteins that are coded by that mRNA. And there really isn't anything unusual to go across a placenta to be able to affect an unborn child. So the data is really accumulating, showing that the risk of pregnant women to get COVID is exceptionally high. If they get COVID, their medical outcomes are very bad. I talked to someone who is in the ICU at U of U the other week, and she said she's had like a string of pregnant women come in on ventilators and they had to do emergency C-sections because both mom and baby were in distress because the mom has COVID. So those are definitely occurring, whereas we are not hearing anything about bad outcomes with babies or moms who've gotten the vaccine. So I think I can understand the initial hesitation, but now the data's in, and we have so many people who have received these vaccines, and they are so safe that it really becomes really important to get those women vaccinated.
And I know that you are still struggling to get providers as vaccine administrators in certain areas of the state. And I just wondered if you could talk a little bit about how that's going. If there's anything that you could share with this group. I realize this is a small group, but everybody has friends, everybody has colleagues. And I think, you know, even if this group is all very pro-vaccine and very on board, it doesn't hurt to share your message with them when they're out at conferences and whatnot.
Yeah, you're right. We have still had fairly low uptake by providers. I think a lot of people were concerned about the ultra low storage containers and like having to use it in a very short period of time. A lot of those restrictions have been loosened. And so the cold ultra storage things are, you can store these vaccines at regular freezer temperature for a certain period of time. And much longer than what we were thinking in the beginning. And also you have a longer period of time to use up your vials. We also, this goes back to the world vaccine, but we also are saying, even if you aren't using your entire vial, it's still useful to get those shots in the arm. So I think there are a number of providers that are worried about the cold storage. They're worried that they aren't going to be able to give the full vial. And we're really encouraging people one is simpler to store than we initially had. And two, even if you don't use the full vial, getting those shots in arms is so valuable that we really encourage people to do it.
Thank you.
I just put up another slide since we have time. I thought it would be just useful to talk about our other treatment option. The one that we have is monoclonal antibodies, as you know, and I just wanted to put this out there because I know all of you have patients who come up positive. So just to know there is options out there. So we do have monoclonal treatments. We are targeting these people to people who are more likely to get severe disease. It is generally then vaccinated who are eligible for monoclonal. And I keep trying to tell people like, monoclonal is the Band-Aid. It's like what we have to do when we have no other option. It's not a great solution. The solution is vaccination, but the Band-Aid, we can give it to people when we need to. So it is a 2-hour infusion of antibodies. They do have some sub-Q options, but my understanding is that is actually fairly miserable because you get quite a large amount of volume put in sub-Q, which hurts. But in general, we're trying to target people with more severe disease. And actually, there is a website on the Utah government, utah.gov website that gives you really the breakdown of who's eligible, and people can go in and sort of just see if they're eligible or not. And it gives information of where it's available. And then other treatments, so ivermectin, hydrochloroquine, nebulized hydrogen peroxide, those would not be treatments, right? So we still occasionally hear of people getting these, and really the data is not at all suggestive that these are helpful. In fact, they're quite harmful. So really trying to get people to stop taking these. I know a lot of it's not through physicians, they're getting it through feed stores, for the example, the ivermectin, but really reinforcing those aren't treatments. And then we are going to have treatments probably coming out in the next month that are these two different things. One's a long-acting monoclonal antibody, so an antibody that you can give people before they test positive. And so it's about an 8-month protective period. I had to say, as a physician, I'm like, how do you get an antibody to stick around 8 months? But I guess they have some modification of them that your body does not filter those out. And also we have antiviral medications that will probably come out pretty soon, but they're going to be restricted to people only who test positive very rapidly. Again, I really encourage us to think of those as Band-Aids and not solutions. I do not want people to go get long-acting monoclonals instead of getting vaccines, because actually the data on long-acting monoclonals is much less than the data on vaccines. So safety and efficacy are much less studied in these than in the vaccine. But I do want you all to know about these, and we expect those to come online fairly soon. One of the antivirals does have some pretty concerning mutagenesis potential, as well as not huge efficacy. So I don't know if Utah is really going to adopt that one, but we think it probably will be FDA approved, or EUA, in the next few weeks. So I just wanted to put those out there since we had time.
Thank you so much. Any other questions before we wrap up today?
I was just going to make a quick comment. Thank you for sharing that. So I do a lot of locums emergency medicine, and we, as the ED staff, because we have docs that come from all around the region. And there were notably 2 docs from Idaho and Wyoming that were wanting to push ivermectin to the patients that were coming in positive for COVID in the ED. And at this facility in northern Minnesota, we actually had to put signs that said, you are not allowed to prescribe this. But it was really only targeted at the 2 docs out of the like 40 on staff. But
Yeah.
I just thought that was a little tongue-in-cheek and humorous. And I'm like, do we really need to do this?
Yeah, it's really unfortunate that I guess social media is more powerful than science for some people these days. So, and then the other thing is I have tried, and I suspect all of you are the people talking one-to-one about these to patients. So you probably all have better ideas than I do, but I've been trying to read up on like what is good ways to message these with different populations. And my understanding, looking at the data we get in, which is possibly not reflective of all your populations you're serving, but that a lot of Utahns who aren't vaccinated right now don't like that the government's pushing them. They don't want to be told what to do. And it's this sort of freedom to make a choice, even if the choice is detrimental. The things I've heard is a lot of messaging to do like, self-empowering the person, being like, well, this is your choice. You can take control of your life. You know, you can take control of whether or not you have COVID or not, and it's your choice to get the vaccine. And maybe phrasing it more that way than to say like, because my understanding is the protecting a community doesn't resonate well with these populations. So it doesn't work very well to say like, you might not get bad COVID, but you don't want to pass it to other people. That doesn't resonate super well. But the control, and it's your option and your choice, and being able to return to your life the way you want to is possibly the more useful way. I don't know if anybody has found super useful approaches.
I've had several, but my most poignant one was a patient that came in asking for an exemption letter because he works at a company that required vaccines. And at the end of the visit, we left friends and we left with the idea that we're going to agree to disagree. We talked about the side effects. We talked about why he didn't want to get it. And really when it came down to it, it became a pride issue because he had said all along he wasn't going to get it. And it was interesting. The next morning I came into the clinic and he had come into our urgent care that night and gotten a vaccine when he went home and thought about it. I've had 5 now that specifically have come in for exemption letters, and 2 of them plus him have gotten a vaccine. So I think there's really hope on the horizon that when we have the time and it's not one of the 5 or 10 minute visits. That's a problem. You have to sit and talk and go through each of these things with them and validate their concerns and understand where they're coming from. But it's really rewarding when that happens.
I totally agree. I've had patients that didn't want to have the vaccine. They were saying, no, it's going to put a tracker in me. One couple, they both came down with COVID. She ended up in the hospital, had a stroke at 42. By the time we discharged her after the 10-day hospitalization, she said to me, I don't know why I went down that rabbit hole of anti-vaccine, conspiracy theories. When can I get a vaccine? It was like, wow. Which was a little, but that was a big change for her. The other, I'd been talking with someone who was kind of religiously very thinking this isn't what to do. And my cousin who's said to this friend of hers, so this is more personal experience, not a patient. She said, well, let's pray about it. Let's pray about it. What do you think? So they prayed and prayed. And then she came back the next day. She said she had a vision that Jesus was in a waiting room getting a vaccine. And she said, well, I just knew right then and there, if Jesus would do it, I'm going to do it. And I thought, wow. And so, people have to slowly come to their own decision, have to be able to change from that being so anti to then seeing why they would want. And I've also tried to convince them that you're really trying to protect others that might get super sick. So this is really the most loving thing to do, is to get the vaccine. So when you feel like that, you're ready to do that. I'm ready to support you. So those are kind of the ways I've been approaching and have gotten a lot of people to slowly change and get the vaccine.
It's interesting, your comment, Dr. Cope, about having just come from South Africa. I hope you're well. Their vaccine hesitancy is quite high.
It really surprised me because I thought the problem, and I don't know that I can generalize this to everybody. I clearly not, because I don't know the data, but my expectation was they just didn't have access to the vaccine. And we were in Botswana where I had the conversation with the folks specifically about that, and anybody could go get the vaccine, but in the particular village we were at, there were only 2 people that had been vaccinated out of probably 800. And it was not for access, it was for fears. It was the same as the polio vaccine in Afghanistan. People just think we're out to get them.
Dr. Ferguson, you raised your hand.
Oh, yeah. I was just saying, I had 2 stories of people that were hesitant, and it was actually recently locally. So my organization, BPOU, was part of a mass vaccination event with the Jazz at Vivint Arena. And people were walking by. They said, should I still get this? And then I said, what are you planning to do for the holidays? Well, I want to go see my grandmother. I said, is your grandmother vaccinated? And they said, yes. And actually, 2 people, and the other 3 were about keeping their jobs that I convinced them. But these 2 women said, and they were in their, they were the sort of that demographic with the highest spike and spread. So that she was like late 20s, early 30s. And she said, yeah, my grandmother, on both sides of my family, I can't see them because they won't let me in the house because I'm not vaccinated. I said, well, grandma's making the right decision. Wouldn't you want to see your grandmother? So I've been trying to take the tack of, do you want to have increased access to your family? Do you want to have increased access to social gatherings? Do you want to maintain employment? Then I recommend you get it, but you can always choose not to. But those are things that you're choosing to close the door on.
And so Tooele actually has a billboard campaign up that says something along the lines like, just get vaccinated, you don't have to tell anybody. Like, that there is now this pride attached to it. And like, well, if you still want to act anti-vax, well, still just go get it. Might be useful.
I've had 3 patients made me promise not to tell their spouse they were getting it.
Wow.
Yeah, you think about that. What a polarization.
Thanks,
And
everybody.
thank you all from my side. You all are the like warriors on the front line. So I really appreciate all that you do. And I feel like it's my job to try to get you the info. And if you realize there's info that's helpful, let me know, because that's what I can do to get you all suited up best you can.